Thank you all very much. I'm very happy to be here with you today, and I'm here to talk to you about two very different things in DADA2, but very important, namely the stroke cohort we see at the NIH, and as well the hepatic manifestations of disease. So because I'm the first, and we're going to hear a lot of this today, I'm going to give you one of the proposed mechanisms of how this disease works. You're going to hear other proposed mechanisms throughout the day-to-day, which will be very interesting. But in a rudimentary sense, when you have low ADA2, as we believe that it is a growth factor for endothelial cells, instead of getting nice, healthy endothelial cells, you get a good disruption within the vessels. And then conversely, when you have ADA2 present, it helps to promote the anti-inflammatory M2 macrophage development. But when you're lacking the ADA2, you don't get that, and instead you get a predominance of the M1 inflammatory macrophages, which can go on to release TNF-alpha, which will cause inflammation. You bring those two separate pathways together, and what you see is ultimately the clinical manifestations of disease, which we see as the fever, the rashes, the strokes, and the polyarteritis nodosa, or PAN. So in our NIH cohort, we have 25 total patients. 12 of them are female, 13 are male, and within that we have 3 sibling pairs and 1 sibling triad. Notably, we do not have any patients who have the pure red cell aplasia or bone marrow failure, and our patients have mild to no immunodeficiency. In fact, the most common thing we see is a low IgM in our patients. When you look at a mutation breakdown within our cohort, you see that the G47R and the R169Q mutations are the most common, followed closely by the Y453C and G47A. There are a couple of mutations that have 2 patients in our cohort, and then we have 14 patients who carry a single mutation that no one else shares. So within our cohort of 25 patients, 17 of them have had strokes. Cumulatively, they have had a total of 58 strokes, and the median age of onset is at just over 4 years of age. 10 of the 17 have their first stroke before the age of 5 years, and the oldest patient in our cohort at the time of his first stroke was 12. And from a location standpoint, the breakdown of the most common areas is as follows. There are 10 of our patients who have had brainstem strokes, 9 thalamic, and then 5 patients with internal capsule and 4 with basal ganglia. There are other areas, as you can see in the picture on the right, that's a corpus callosum lesion, and we do have 2 patients who have seen that. Not only do we see the ischemic strokes, but we do have 4 patients in our cohort who have had hemorrhagic strokes as well. 2 of the patients have had 2 separate events, so we've seen 6 total hemorrhagic strokes. And when we've done an analysis, all 4 of them were on some sort of antiplatelet or anticoagulation medication at the time of their hemorrhagic stroke. Notably, though, there are patients out there who on no anticoagulation have had hemorrhagic strokes as a presentation of DADA2. When you look at the past anticoagulation history in our cohort, you can see that the vast majority were treated with aspirin, and then quite a few with enoxaparin, clopidogrel, and warfarin. So the nurse practitioner in our group, Patricia Hoffman, decided to do an analysis earlier this year to see if there would be an increased risk of having these hemorrhagic strokes if you were on any of those anticoagulants. And when she looked at the all-comers and compared those who hadn't been on any anticoagulation versus those who had, she was unable to see any statistical significance. But not satisfied with that result, when she broke it down more, she looked at the patients who had been on aspirin alone and then also aspirin with another agent on board. And it was then that we had the significance rise to the threshold. And it seems that when you're on combination therapy, the risk for having a hemorrhagic stroke goes dramatically up. As far as the cohort goes, from a more inflammatory ischemic analysis, you can see that they've been on a lot of different medications. The vast majority of the stroke patients were on prednisone, and then you can see that there's a number of biologics, including the anti-IL-1 agents, and also a myriad of disease-modifying anti-rheumatic drugs. However, it is important to know that when you look at this entire list of medications, we had our patients stroke through any combination of them. So prednisone, although it can reduce the inflammatory burden, does not prevent a stroke from occurring. So when we saw these patients initially, the question was, well, what do we do? They have seen so many different medications. And when we had done biopsies on our patients, and then we stained them looking for TNF, the two at the bottom are the controls. And as you can see, there's just a nice, quiet blue staining. But when you look at the above, where we have the patient samples, the red is indicative, especially on the right, of TNF-alpha being present perivascularly and within the vessels. So that, coupled with word of mouth coming from our colleagues over in Israel of a couple of their patients who had done well on anti-TNF agents, we decided to start implementing anti-TNF treatment in our DADA2 patients in June of 2013. So each one that's come through our door since that time, we have strongly recommended that they start treatment. Earlier this year, I decided to take on looking at how effective have we been with this treatment. We have been starting the vast majority of them on etanercept simply because it's very easy to dose that in a young child because it has a good milligram per kilogram dosing regimen. We also have patients on adalimumab and golimumab, but I know that out there within the world, there are others who are on the other anti-TNF agents. So in my analysis, I looked at the 17 patients and calculated up that prior to anti-TNF initiation, they had amassed 1,173 patient months, and during that time, they had had 55 strokes. Time zero for measuring the patient months was the time of their first ischemic event. Post anti-TNF initiation, we had amassed 373 patient months, and in that time, since we had started treatment, we have seen absolutely no strokes. That is a very statistically significant result, as you can see listed there. However, for those of you who may say, well, we tip the scales in our favor, we also, to verify this, did a matched follow-up time analysis, where we took the time going forth with the anti-TNF agents and then also applied it retrospectively. So prior to anti-TNF treatment, we had 328 patient months, and during that time, there were 30 strokes. And then going forward, 328 patient months, we saw zero. Once again, very strongly significant. Another thing I want to point out to you is that these stroke trajectories can be very variable in each patient. As you can see in patient A, he had a very aggressive 2-year period of time where he had 7 strokes. He was tried on all these medications and continued to have this very bad course. When he started on etanercept, as you can see, everything stops. And then in patient B, he had 1 event, and then on absolutely no treatment at all, had nothing, no symptoms of any sort of disease for a few years before he had 2 strokes in rapid succession. So we get asked a lot of times, I'm feeling good, do I need to continue on this medication? We don't understand why this disease ebbs and flows the way it does, but we strongly recommend that everybody continue on anti-TNF regardless of symptoms that they may be having. Not only have we seen a cessation in strokes, but we've also seen some very significant laboratory improvements in our patients. You see that the inflammatory markers have a sharp decline from when they first present to us. And we do see hematologic improvement. The platelet count decreases. Noting that at the bottom we have 3 patients marked by an asterisk. Those are 3 patients who have portal hypertension and large spleens, so we believe that their thrombocytopenia is more due to the splenic sequestration. And then we do see their anemia resolve and their iron levels go up. And if you don't believe me that we are seeing great improvement on this medication, I think this slide will tell it all to you. Here we have one of our patients who in June of 2013, at which time she started on etanercept therapy, she was clinically showing the result of being on high-dose steroids. You can see the very prominent libido, her protuberant abdomen due to her very large spleen, and she was requiring a prednisone dose of 0.4 mg per kg per day, in addition to mycophenolate, in addition to anakinra. Just 25 months after starting treatment, you can see she grew 20 centimeters. Her prednisone dose was reduced to absolutely nothing, and she's growing into her spleen size. It's still big, but we are not seeing the progression that we were. And the libido, although still there, is faded. So now I'm going to switch gears completely and talk to you about the hepatic involvement in our cohort. I'm presenting on behalf of the hepatology crew, Drs. Theo Heller and Hawa Alau, who were unable to be with us today as they are at their National GI Conference. And their study included looking at 24 of our patients and looking at them prospectively. And they would do serial laboratory tests as well as frequent abdominal ultrasounds. And in 4 patients, they did transjugular liver biopsy with measurement of portal pressures. Very early on, it became clear that you could segregate our patient cohort into 2 groups. There were those who had repeatedly high ALTs, of which there were 5 patients, and then the other 19 had normal ALTs. And one measurement they do is called the spleen length height ratio, and it is as it says. They measure the length of the spleen and compare it to the patient height. And when you plot it out on this chart, which has been verified in multiple studies over time, the red line marks the 50th percentile, and the gray is 2 standard deviations above the mean. Those who fall 2 standard deviations above the mean have an increased risk of the development of portal hypertension. The red triangles are all those 5 patients who had the high ALT. There's more than 5 because these were on repeated blood draws over time. But of note, you also see 6 of those green normal ALT patients who are falling above that 2 standard deviation above the mean line, which caused us to scratch our heads and say, we need to look further at this. Are they going to be developing portal hypertension as well? So when you looked at those who had the normal ALT, and we did a full abdominal ultrasound, you can see that the vast majority of them did have splenomegaly, despite not having any GI or hepatic clinical manifestations at all. Compared to those patients, we have those 5 patients with the elevated ALT, and across the board they had splenomegaly, most of them with hepatomegaly, and their hepatic clinical manifestations ranged from nothing to life-threatening, as there's one who had grade 3 esophageal varices that bled massively on 3 occasions, requiring lots of blood transfusions, and ultimately she went on to have a splenorenal shunt, and that, coupled with her etanercept, has kept her from having any further problems. This here is just showing how when the portal hypertension develops and you're doing an ultrasound, you may see the umbilical vein have the flow going back into it. So it becomes reopened, and as you can see by the red there, that's the blood flowing back into the umbilical vein. We did portal pressure measurements in 4 of the patients, as I stated, and looking at the hepatic vein pressure gradient, when you know you are to be concerned is if you hit a level of 5, that's where portal hypertension's definition starts. And once you hit above 10 is where you really start to see the secondary complications from portal hypertension, like the hemorrhoids, the varices, etc. 2 of our patients did have the portal pressures greater than 10. And then in our liver biopsy specimens, what those arrows are pointing to are dilated sinusoids. And you can see those in a congested state, but also you can see them in inflammatory conditions or vasculopathies, and that's what that's representing in these DADA2 patients. In the next slide here, we have a portal region, and the arrow is pointing at a compressed portal vein. And the reason it's becoming compressed is that as the liver disease is progressing, the liver doesn't have the flexibility that it once did, therefore they become much narrower. And then in this slide, you see the staining done with CD34 staining for endothelial cells that line the sinusoids. And typically in a healthy state, there would be no staining because the healthy endothelial cells are fenestrated. So when you attempt to stain, the stain will go straight out and diffuse, and you won't have the staining. But when you have a diseased liver, like you see in our DADA2 patients, the architecture of those endothelial cells gets distorted, and you lose that fenestration. Thereby, you see the staining. And then these are just some more of our observations in these 5 patients. And at the bottom, you see that each one of them classified as having hepatoportal sclerosis. And then on biopsy, 2 of the patients had the more severe nodular regenerative hyperplasia. So because we also had this to show you, we have an endoscopy done on one of the patients at the time she was started on etanercept treatment in June of 2013, and these arrows are showing esophageal varices that were present. We repeated this endoscopy just a year later, and we had complete resolution of the varices without any other treatment aside from the etanercept. So a hepatologic summary is as follows. is that the majority of patients with DADA2 have hepatosplenomegaly despite having a normal ALT. And then almost half of those who have the normal ALT had the spleen length height ratio that was suggestive of developing portal hypertension. And those with the high ALT had the histological evidence of liver disease. And of course, anti-TNF treatment has resulted in resolution of the gastroesophageal varices. So in conclusion of all that I've had to say, the anti-TNF agents significantly reduce the risk for stroke in the DADA2 patients with a history of stroke. And then across the board, with those with hepatic involvement, it reduces the portal hypertensive related clinical findings, improves the cutaneous manifestations of DADA2, and also improves any of the GI symptoms if they were having frequent abdominal pain, improves their hematologic studies, and reduces their inflammatory markers. And also, DADA2 is strongly associated with non-cirrhotic portal hypertension and hepatic involvement. So thank you all very much. I look forward to hearing the rest of the day.